Hello, and welcome to the modeling background tutorial for the COVID-19 simulator developed as part of the EUVABECO project. This presentation will show you the mathematical model that works in the background of the simulator. Understanding this model will help you interpret the simulator's results. The simulator allows you to explore what-if scenarios. For example, what would have happened if vaccinations had started earlier, or if a new virus variant had appeared at a different time? During the COVID-19 pandemic, a major concern was predicting how many infections and hospital patients to expect in the coming days or weeks. Mathematical modeling is a powerful tool to answer such questions. Therefore, during the pandemic, we developed a model for Germany and its federal states. It describes infections, hospital and ICU patients, ventilated patients, and fatalities. Within the EUVABECO project, the aim was to adapt this model for other European countries, including Poland, Greece, and Luxembourg, and to integrate the adapted models into simulation tools for counterfactual analyses. Over the course of an infection, patients pass through several stages of disease. First, they become infected and can infect others. Second, they experience sickness of varying severity. Third, they either recover or die. The transitions between these stages depend on various factors, such as the patient's age, the virus variant, or protection through vaccination or non-pharmaceutical interventions like lockdowns. Understanding these factors is key to building a good model. To build a mathematical model, observed data is needed. For Poland, the government made key pandemic data publicly available starting in January 2021. This data included daily infections, hospitalizations, fatalities, and testing numbers. Infections and testing numbers were additionally available stratified by province. Additional data on age-stratified vaccinations and variant spread was obtained from the European Center for Disease Prevention and Control. Where Poland-specific data was not available, for example, regarding disease duration or age-specific hospitalization risks, the model was informed by data from Germany. There, where we had built the original model using a more comprehensive database. The first part of the model follows a standard epidemiologic model for infectious diseases. It separates the population into three groups from top to bottom. First, the susceptible population, people who are not immune and can get infected. Second, the infectious population, people who are infected with COVID-19 and not yet in quarantine. They can still infect others from the susceptible population. And third, the population with a confirmed infection. These individuals are in quarantine and cannot infect others. They are also assumed to be immune, so they cannot be reinfected. Each of these three states is described by one mathematical equation. The number of susceptible people that one infectious person infects on average is called the reproductive number RT. If RT is above 1, each infected person infects more than one other person on average, and the epidemic grows. If RT is below 1, the epidemic shrinks. This number changes over time, for example through lockdowns, behavioral changes, or new virus variants. That is why it is written as RT, with T standing for time. On the right side, you can now see the model results. The top row shows the input data, the spread of virus variants over time, and the vaccination trajectories in Poland. Below, on the left, is the model estimated reproductive number, RT. You can see how it fluctuates over time, reflecting changes in restrictions and population behavior. On the bottom right is the weekly incidence per 100,000 inhabitants. The dots represent observed values from Poland, while the line represents the model prediction. As you can see, the model captures the observed infection dynamics well. Poland is divided into 16 provinces. For each, the number of cases and fatalities was available. Here you see the estimated reproductive number on the left axis and the incidence per 100,000 inhabitants on the right axis, combined in one plot per province. You can see that the model captures the observed infection dynamics well in each province. The model was then extended to differentiate between patients treated at home and hospital inpatients. Several factors influenced who ended up in which category. Vaccinations protected patients from severe disease. Higher testing intensity meant that more mild cases were detected, which increased the proportion of ambulatory patients. Older age and male sex were strong risk factors for hospitalization, and different virus variants were associated with different disease severities. Finally, patients from both ambulatory treatment and hospital care could either recover or die from COVID. These clinical outcomes again depended on several factors. The risk of death was higher for patients requiring inpatient or ICU treatment, and for older and male patients. The risk also varied across virus variants. Vaccinations provided protection against fatal outcomes. Additionally, recovered patients were not necessarily protected forever. The model allows for reinfections, specifically for individuals who recovered from wild-type, Alpha or Delta, and were later exposed to the Omicron variant. This structure now represents the full model. For each of the colored compartments, observed data was available against which the model was fitted. In total, 24 differential equations are needed to describe the flow of patients through all these stages. Here, you can see how the disease stages of COVID-19 were translated into the model stages you just learned about. These, in turn, were translated into systems of mathematical equations. Each box and each arrow from the previous slides corresponds to one or more equations that describe how patients flow between stages. You don't need to understand these equations to use the simulator, but this gives you an idea of the mathematical foundation working in the background. In the plots, you can see the numbers of infections, inpatients, and fatalities in Poland, the observed numbers as points, and the model predictions as lines. Additionally, you can see the trajectories of some variables influencing the relationship between the outcomes, namely the number of tests, the spread of virus variants, and vaccination coverage over the course of the pandemic. Notably, in February 2022, daily case numbers peaked while hospitalizations remained lower than in spring 2021. This was largely due to the Omicron variant causing less severe disease. Here we see the overall results of the developed model for the Polish provinces. All observed data from Poland is shown as dots, and model predictions as lines. The key takeaway from this overview is that the model describes the pandemic trajectory in the Polish provinces well over the entire pandemic period. Since our model was originally developed for Germany, it is instructive to compare the pandemic settings in both countries. This comparison also helps us understand some of the modeling choices we made for Poland. Because Poland and Germany differ vastly in population size, all indicators are shown per 100,000 inhabitants to allow for a meaningful comparison. Blue lines show the pandemic trajectories for Poland, and red lines show those for Germany. The thicker lines show the trajectories for each whole country. The thinner lines show the trajectories for the provinces or federal states where data was available. Variant of concern trajectories were similar. Initially, vaccinations followed similar trajectories. However, Poland reached lower vaccination rates and substantially lower booster rates. There was more testing in Germany. However, the fraction of positive tests did not show a specific trend. The trajectories of the reproductive number and the incidence on the right side were largely parallel between both countries. This slide shows the number of cases, hospitalizations, ICU patients, and fatalities as predicted by the model for each federal state or province as thin lines and for each whole country in thicker lines. Throughout the pandemic, the ratio between hospitalizations and fatalities was higher in Poland. This does not mean that disease was more severe in Poland. Rather, it reflects that Germany's more extensive testing captured a larger share of mild cases, bringing the ratios down. This is an important insight because it influenced how we calibrated the hospitalization model for Poland compared to Germany. Additionally, the variability in infection numbers, hospitalizations, and fatalities was higher in Germany. This reflects the less concerted political interventions within the federal state system of Germany. Now I want to show you an example of the counterfactual simulations I mentioned at the beginning. The simulator allows us to explore what-if questions by changing specific parameters and observing how the pandemic trajectory would have changed. For this example, we look at the beginning of 2021, when the emergence of variant Alpha and the rollout of vaccinations happened in parallel. The questions we want to answer are: what would have happened if Alpha had appeared just 1 week earlier? And could a different vaccination strategy have counterbalanced this earlier appearance? Both of these questions can be answered by performing variant modifications and vaccination scenarios in the simulator. The results show that if variant Alpha had appeared 1 week earlier, the peak incidence would have increased from 28,100 to 38,200 cases per day. Could vaccinations have counterbalanced this? An increase of vaccinations by 25%, shown in violet, would have reduced the peak to 34,000, and the combination of an earlier start by 1 week plus a 25% increase, shown in yellow, would have brought it down to 31,100. So while vaccinations helped, neither scenario could fully offset the impact of the earlier variant appearance. A similar trend can be seen in the hospitalization numbers. Importantly, though, the increased vaccinations show a substantial long-term effect, as you can see in the later part of the curves. However, this trend of case numbers approaching zero is an important example of where the model reaches its limits. In reality, as case numbers drop, restrictions would have been loosened and people's behavior would have changed, leading to new increases. The model, however, assumes that the underlying dynamics remain the same regardless of the altered scenario. This is why long-term predictions from counterfactual simulations should be interpreted with caution, which brings us to the model limitations I will discuss next. The model has several limitations caused by assumptions we had to make due to lack of information. First, the model assumes lasting immunity following infection. The sole exception is Omicron reinfections among individuals previously recovered from wild-type, Alpha, or Delta. Second, while the model adjusts hospitalization rates for testing intensity, no undetected infections were explicitly included. This means that immunity following an undetected infection is not accounted for. However, these two limitations have opposite effects. One overestimates susceptibility, the other underestimates it, so they may partly counterbalance each other. Third, vaccinations were only stratified by the first full vaccination and the first booster. Later booster vaccinations were not accounted for. These limitations all cause uncertainty regarding the population's susceptibility to further infections. Therefore, model predictions far into the future must be interpreted with caution. As we just saw in the simulation example, short-term effects were captured well, but long-term projections are less certain. To summarize, the mathematical model that powers the Poland COVID-19 simulator describes the pandemic trajectories well across infections, hospitalizations, ICU admissions, and fatalities in Poland and the Polish provinces. We identified and implemented various factors influencing virus spread and disease severity, including vaccination rollout, variant characteristics, patient age, and testing intensity. Some of these factors can be altered within the simulator to explore counterfactual scenarios, as we just saw with the Alpha variant example. When interpreting simulation results, keep in mind the model limitations we discussed, especially for long-term projections.